Laparoscopy, surgical, proctectomy, complete, combined abdominoperineal, with colostomy. Proctectomy, combined abdominoperineal pull-through procedure, e.g., colorectoanal anastomosis, with creation of colonic reservoir, e.g., J-pouch, with diverting enterostomy, when performed. What is the appropriate code to report for a laparoscopic proctectomy and a colorectoanal anastomosis with creation of a J-pouch? Code 45397, Laparoscopy, surgical, proctectomy, combined abdominoperineal pull-through procedure, e.g., colorectoanal anastomosis, with creation of colonic reservoir, e.g., J-pouch, with diverting enterostomy, when performed, would be reported for this procedure. Laparoscopy, surgical, proctopexy, for prolapse. Proctopexy, for prolapse, with sigmoid resection. The physician performs a laparoscopic proctopexy, or rectopexy, for correction of rectal prolapse. Using a laparoscope, the physician completely mobilizes the rectum down to the pelvic floor and attaches the rectum to the sacrum using polypropylene mesh. The mesh is initially stapled to the sacral hollow and sutured on both sides of the rectum. The trocars are removed and the incisions are closed with sutures. In 45402, a laparoscopic sigmoid resection is performed in conjunction with the proctopexy. Using a laparoscope, the physician mobilizes the sigmoid colon and rectum. The redundant segment of sigmoid colon and rectum are excised and an anastomosis is created between the remaining bowel ends with sutures or staples. Following laparoscopic proctopexy as described above, the trocars are removed and the incision closed with sutures. Laparoscopy, abdomen, peritoneum, and omentum, diagnostic, with or without collection of specimen, S, by brushing or washing. Biopsy from any or all of the areas observed are obtained by brushing the surface and collecting the cells or by washing, bathing, the area with a saline solution, and suctioning out the cell-rich solution. Laparoscopy, surgical, with biopsy, single or multiple. With aspiration of cavity or cyst, e.g., ovarian cyst, single or multiple. With drainage of lymphocoel to peritoneal cavity. With insertion of tunneled intraperitoneal catheter. With revision of previously placed intraperitoneal cannula or catheter, with removal of intraluminal obstructive material if performed. If biopsy of pelvic organs is performed, the physician may also insert an instrument through the vagina to grasp the cervix and pass another instrument through the cervix, into the uterus to manipulate the uterus. The physician uses an aspirating probe to aspirate a cavity or cyst or to collect fluid for culture. The physician drains a lymphocoel to the peritoneal cavity. The lymphocoel is identified and instruments are passed through to open and drain the lymphocoel. A permanent intraperitoneal catheter is inserted laparoscopic for continuous drug infusion, such as insulin, morphine, or chemotherapeutic agents. If the physician is inserting a totally implantable, intraperitoneal drug delivery system, the pump reservoir is secured into a surgically prepared pocket in the subcutaneous fat of the lower or mid-left abdomen. The infusion line catheter from the pump is placed inside the peritoneal cavity with the tip free moving. If the physician is revising an intraperitoneal catheter, the catheter is inspected and freed of occlusion or blockage. Laparoscopy, surgical, with omentopexy, omental tacking procedure. With placement of interstitial device, S, for radiation therapy guidance, e.g., fiducial markers, dosimeter, intra-abdominal, intrapelvic, and/or retroperitoneum, including imaging guidance, if performed, single or multiple. The physician isolates the omentum at the stomach and intestine and may cut, suture, or plicate omental tissue to achieve the desired effect.